the impaired renal function. With these postulates granted, let us survey the two striking characteristics of the impaired renal function. These are diminished excretion of solids, lack of flexibility. Diminished excretion of solids. Excretion of excrementitious solids in watery solution is the cardinal function of the kidney. The gravity of any disease of this organ is measured best in terms of lack of efficiency in this, its excretory function. But this function is a very complex one. No test or combination of tests measures it with precision. Yet, as already noted, impairment of excretory function by infection is measured with a fair degree of accuracy by the excretion of urea. A little less accurately by specific gravity, a little more so by urine and blood nitrogen and freezing point, and by the phenol sulfonaphthalene test. Urea estimation. So overshadowed is urea by phenol sulfonaphthalene that there is a general tendency on the part of urologists to omit altogether the collection of 24-hour specimens of urine for quantitative test. But the 24-hour specimen should be depended upon for two data, viz. The total quantity of urine passed and the concentration and total quantity of urea. The total quantity of urine, if between 1,000 and 2,000 cc's, does not tell us much, but it exceeds these limits only because of an unusual excess or diminution of the intake of fluids, excessive perspiration, or an impairment of kidney function. Pathological oliguria may mean obstruction to the outflow of urine, acute congestion of the kidney, as in acute Bright's, or grave chronic impairment of kidney function. These conditions may be readily distinguished by collateral investigation. Polyuria is characteristic of certain types of chronic renal congestion, as in tuberculosis, stone, prostatism, retention. The polyuria of nervousness, of arteriosclerosis, and other non-surgical conditions do not concern us. The total quantity of urea passed for 24 hours should exceed 45 grams. 50 grams is regarded as normal. Physiological variations in the total urine do not materially affect the total urea, but disease of the kidney reduces it. The diminution of total urea is not, however, a good index of renal disease. Neurasthenia, for instance, may reduce it to 30 grams or even less. The concentration of urea, grams per liter, is in one sense an indication of health, for the diseased kidney shows its reduction of function very largely by its inability to excrete solids. Hence, the concentration of urea by a diseased kidney is always relatively low. There are many physiological agencies that interfere with urea concentration. Thus, a very dilute urine may be passed as the result of nervousness or of drinking large quantities of fluid or of arteriosclerosis, quite independently of the condition of the kidney itself. Hence, lack of urea concentration is no evidence in itself of disease of the kidney. On the other hand, the presence of urea concentration is an evidence of health of the kidney. A urea concentration of more than 18 or 20 grams to the liter is evidence of a sound kidney. Footnote: Yet a patient of mine died of acute renal congestion 53 hours after nephrectomy, having passed about 600 cc's of urine, one portion of which showed a concentration of urea amounting to 33 grams to the liter. But urea estimation of the specimens obtained separately from the two kidneys by the ureter catheter is of the greatest value. The urine passed simultaneously by two normal kidneys should show a urea concentration which is either absolutely equal or varying not more than 5%, i.e. 1 gram in 20. But urea variations are subject to unaccountable physiological changes and are in general less marked than the corresponding variations in phenol sulfonaphthalene output. In view of the inaccuracy of quantitative ureter catheter findings, it is prudent to consider urea percentage, footnote, which is the only observation not vitiated by the leakage of urine alongside the ureter catheter, much more accurate than urea volume or phenol sulfonaphthalene percentage. If they all agree, or if the urea volume or the phenylsulfonephthalene percentage vary in the same sense, but to a different degree from urea percentage, the accuracy of the observation is confirmed. But if they disagree, we may have grave doubts as to whether some technical error has not vitiated our conclusions.